Why did the detective stay in bed? Why did the detective stay in bed? Because he wanted to stay undercover. Why do seahorses only like salt water? Why do seahorses only like salt water? Because pepper water makes them sneeze. Think of who wrote it. That was... It's not helpful when Dad says, you know, there actually are freshwater seahorses, just so you know. You're like, Dad, it's supposed to be a joke. Yes. Can I show you a picture of what? Of my family? Oh, yeah. Right now? How about I come prepared before the exam? How's that? I can just see my kids. Okay. This is a good one right here. All right. Yes. Since that's the request. So this concludes our final lecture for this unit, and then on Tuesday what happens? We have an exam. A study guide will be posted likely this evening, by tomorrow morning at the latest, but I'm thinking it's going to be out this evening. I'm getting nods that that was accurate information. SI times, there is an SI session late on Monday evening, because the reason for that time schedule is if we want a large enough classroom to fit the numbers that we anticipate, we actually have to wait until the lectures are done in those classrooms. And so that's one of the reasons that the review session, the SI session on Monday evening before the exam is later in the evening. Okay? Should be similar to what we've had in the last two exams as far as style. We'll have some questions on the screen. They should be familiar images or figures that we've covered in lecture. We'll still have 50 multiple choice. Same. You know, by now, mid-semester, you should be pretty familiar with the whole process. Okay? Midterm grades are posted if you didn't see that announcement. So a caveat on the midterm grades, it does not include the work you're doing this week. So it does not include the bonus opportunity. It doesn't include worksheet 3 or quiz 3. And the reason for that is because I need the grades done before Friday, and the worksheet or the quiz 3 closes tonight, and bonus opportunity closes on Friday. You guys remember that? Okay. And the other caveat is it's not dropping your lowest assignment yet. So at the end of the semester, we'll drop your lowest quiz and your lowest worksheet. We don't drop any of the exams. Lowest quiz and lowest worksheet. But that gives you kind of a sort of a get out of jail free pass. Any questions about the exam on Tuesday? There will be some cumulative type of questions in a similar way that you saw in the last exam. So 5 to 10% cumulative. And they're cumulative concepts. You know, I wouldn't anticipate that you're going to need to know mechanisms that you've already been tested on. These are more cumulative type of concepts. Cool. All right, so we're finishing out the central nervous system. And in this component, we're going to start looking at the spinal cord, and we're going to look at these major regions of the spinal cord. And the major regions, if you remember back to lab, the cervical is in the neck. The thoracic is found in the chest region. Lumbar in the lower back. And then you have the sacral region. That's basically your tailbone. Okay, or remnants of your tailbone. So if we kind of walk through each section and we look sagittally from the side, we can appreciate these typical normal curvatures. And so I want to go over this very carefully because there's a lot of times some confusion. We say there's cervical lordosis. Well, cervical lordosis is normal. The cervical lordosis is the curvature of the cervical region of the spine. If you're looking from the front or the anterior view, it's convex, right? And then kyphosis from the anterior view is going to be concave. And then again down here in the lumbar region, you again see a lordotic angle. It's convex from the anterior view. And then again, you see this terminology kyphosis, which matches the thoracic angle. So this is, the kyphotic angle is this angle that is concave, like what you see in the thoracic region as well. So they sound like diseases, right? But they're just talking about a curvature shape. Now, when we see exaggerated or abnormal thoracic kyphotic angles, then that means it's not normal curvature, it's exaggerated, right? It's abnormal. And that would be like the hunchback situation that we see in a lot of older patients. So don't be tricked on the exam. I'm not trying to trick you because I'm explaining it to you right now. But this is not a disease state. It's not like there's anything wrong with the spine. There's no lordosis problem. There's no kyphotic problem. But these fancy words make students think that there's some pathology. There's not, if you use it in this context. If you say that we have an abnormal lordotic curvature of the cervical spine, now obviously something is not normal here. Okay? Make sense? So if you think about the architecture of the spine from the lateral aspect, we all start out with this C shape embryologically. We all start out with a C-shaped spine in utero. And that C-shaped spine is where the thoracic region and the sacral region get their original shapes. And that's what we call our primary curvature. And because we know that bone remodels based upon the stresses or the forces that it's placed under, possible great review question, right? That was from the last unit. But in this example, if we wanted to talk about that concept, how would you refer to that concept by name? Anybody remember? It's called something law. Wolff's Law. You guys remember Wolff's Law? So as we develop, one of the first things that we do as a young infant is we start lifting our neck, right? We start lifting our neck up off of the floor, looking around. And that happens early in development, really before you start crawling. And so now the cervical spine remodels from a C shape to a convex shape from the anterior aspect, and that's that lordotic curvature. That's that secondary angle that you get. Okay? Then, and the vertebrae change their wedge shape to accommodate that new curvature because the bone can remodel based on Wolff's Law. Now, later on in development, usually about 12 to 24 months, about the average of 18 months, some kids start walking earlier than others, you move from a crawl to a walk, right? And now your pelvic girdle kind of sits up underneath everything else. And in order to balance, right, you kind of push out this portion as you're trying to balance. And here's where our next remodeling takes place. So after you're fully done growing, right, you have this lordotic curvature, you have the original curvature, the kyphotic curvature, you have a new lordotic curvature, and then you have the original kyphotic curvature. And you can imagine there's all sorts of back issues that you come in contact with, right? Yes. I mean, so if you don't have back issues, I guarantee you somebody that you know does. Probably mom or dad. You know, I was like, oh my gosh, I just slept wrong, my back's all wonky, right? Like, good morning, Dad. You know, that's usually how it goes. So, because of this curvature and the nature of this spine, it's very easy for it to get out of alignment. And there's whole fields of study on this, right? Chiropractic medicine, its original roots with osteopathic medicine were very common. They were back to sort of the original individuals. And then at some point they split. chiropractic medicine went one direction, and osteopathic medicine, DOs, went a different direction, right? And of course, in physical therapy now, which is a more recent field, believe it or not, physical therapy is a rather recent field in comparison to medicine. Classic allopathic MD training or chiropractors have been around a really long time, back into the 1800s. Same with osteopathic physicians. And we have whole fields of study about the orientation of the spine. So this segment is kind of interesting. We're talking about the spinal cord and the function of the central nervous system, but we're also going to talk about some of the housing that protects that spinal column, and that would actually be this vertebral column. So if we walk through each segment, and we start up at the neck region, and we're not going to have time to talk about all the different diseases, right? And in lecture, I'm less important because you've already been tested on this. Do you guys remember in lab when you reconstructed the vertebral column?
Yes.
Did you guys do that activity with sort of the chemistry ring stand, and then you kind of built that structure up? And it's a little challenging, but if you pay close attention, you can actually figure out. It's like putting a puzzle together. Okay? So I know that you know the numbers of vertebrae in each area, and it's really less important that you remember, 7, 12, and 5, cervical, thoracic, and lumbar. It's really less important that you're able to distinguish between the two. Like on the exam on Tuesday, I'm not going to pass out vertebrae and say, tell me what this is, right? Remember that? Did you guys love that game? That guessing game? We're not going to do that on Tuesday. There's not going to be a picture of a vertebrae that says, which one is it? Is it a giraffe or, right, the anteater, right? You guys remember that? So that's what you do in lab, and that's the structure ID, so you figure out where things go. But the structure makes sense, right? I mean, the lumbar vertebrae are lower down, they're more weight-bearing, so they're more robust, they're thicker. The cervical vertebrae are thinner because they only hold up the head, essentially. But what we're going to talk about is we're going to talk about some of the different disorders as it occurs with respect to the spinal cord at these particular areas and the vertebrae that surround them. So the purpose of the cervical spine is to support the head. It provides attachment locations for muscles of the neck and the upper extremity. It protects, obviously, the spinal cord in that region. And there's a large range of motion, ROM, because in the cervical region, we have the ability to do quite a bit with our head and our neck. And there are individual spinal nerves that come out at the level of the cervical spine. And a lot of those innervate the upper thorax, including the arms. So if you have a sort of a pinched spinal nerve that's coming out at about C5 or C6, you're probably going to get arm tingling and maybe arm pain, right? Likewise, if you have trauma anywhere around C5 and up, you're probably going to lose partial or complete ability to control your arms. Now, obviously, you'll lose leg feeling too, but below that, in the thoracic region or at like C7, you're below where the arm would be completely innervated and you would only have paralysis with a spinal cord injury patient in the lower limbs, and you still have range of motion of your upper arms. Okay. If we look specifically at the axis and the atlas, or vice versa, the atlas, which is C1, and the axis, which is C2, we do see unique shapes that determine the functionality of these vertebrae. And so you can see that atlas supports the bottom of the skull. So the bottom of the occipital lobe actually sits and rests right on these condylar surfaces that articulates with those occipital condyles. And this allows for the head to move in the sagittal plane, which is nodding your head yes. And then the axis, which fits underneath it, in this odontoid process kind of protrudes up, and also as an attachment site you're going to see in the next couple of pictures for some ligaments. This structure allows movement in the transverse plane, so that's shaking the head no. And of course we can do the combo of both. Well, this particular anatomy that sits together. You see how this dens, or this odontoid process, kind of protrudes up. You've got a transverse ligament that comes across here. And you're going to have two alar ligaments that attach like suspensory ligaments here that are shown right here. So here's our transverse ligament coming across. Here's our alar ligaments coming in a sort of a sagittal plane. And you can see that this nicely keeps that puzzle shape together, but allows for motion. Well, the problem is in injuries, like for example with a whiplash injury, this is a very weak spot in the cervical vertebral column. And when there's an unexpected rear end accident that causes this flexion extension in an exaggerated fashion, we likely see these ligaments being torn. The alar ligaments, in particular, are very susceptible to strain or rupture in a whiplash injury. So it's the most common injury that takes place in these whiplash patients, about 66%. And dislocation, or a word called subluxation, is not uncommon. When you get dislocation of that joint that we just looked at, then what happens at this allantoaxial joint, you actually get tearing of the alar ligaments that we were looking at before. So these alar ligaments will get torn when this joint actually disarticulates. And this is really a lot of the pain that's associated with it. So in a whiplash injury, it would be not nearly as bad. It would probably be mostly transverse ligament damage if the patient just sat there like this, and you're looking in the rear mirror, oh, they're going to hit me, they're going to hit me, oh, here it comes, here it comes, here it comes. But usually what we do is what? They're going to hit, you're going, oh no, right? You're looking this way, so you're putting pressure, or one of the alar ligaments is strained, and then you get hit from behind, and that's actually what causes it to be compromised. Okay? So whiplash injury is probably, one of the examples you might see on the exam as it relates to the cervical spine. If we look at the thoracic spine, this one is the obvious transition between the neck and the lower back. It's not nearly as movable, right? So, bend your head down, right? Everybody touch your chin to your chest. Nicely done, okay? You could, if you wanted to, you could touch your toes, right? Now I want you to bend right here. Right? Can't really do that. So it's not nearly as mobile because you have the thoracic cage that holds everything in place. And you remember one of the distinguishing characteristics of the thoracic vertebrae were these additional articulations where ribs will attach. You guys remember that? And so that's how you really could tell you're in the thoracic spine instead of the neck or the lower back. But it's still an integral part because it's actually really stable. It's a very stable structure. It's also wedge-shaped. So if we look from a sagittal view, and I've drawn two lines right here to kind of identify the shape of this normal thoracic kyphosis. And if it's going to take a curvature, and from the anterior aspect it's actually concave, that means on the anterior portion, this segment is shorter than this segment. Do you guys see that? It's like a pie wedge, right? A very thin pie wedge, I understand. Okay, you might want bigger pie wedge shapes for Thanksgiving. That's fine. But what I'm trying to let you appreciate is this segment length is shorter than this segment length. Okay? So it truly is a wedge shape. And this is a very common feature. It allows it to have similar gaps between, and what goes in between the different vertebrae? What is it? Intravertebral discs. Very good. We're going to look at those as we look at the lumbar spine here in a moment. Well, in this particular slide, if we superimpose what we learned about with bone density being compromised in patients, and primarily the biggest risk factor is in older postmenopausal women. Not that it doesn't happen in men, but when you have an individual where you've got the weight of the head, arms, and trunk that put pressure on the top part of the curvature of the thoracic spine, and you have density of the bone being compromised. Remember, osteoporosis is a disease. Again, this is a review concept back to the last unit. But osteoporosis is a disease that does what? Somebody tell us, what does it really, what's happening with osteoporosis? You have a loss in bone density, very good. And do you guys remember how it's defined? By the World Health Organization. You guys remember that? That's a little bit too much detail probably for this exam, so that's fair. But knowing that it's a loss in bone density, but I'll just tell you, it's defined as a bone density that's greater than 2.5 standard deviations from your peak bone mass. Okay? That's too much information for Tuesday, but you do need to know what osteoporosis is. You do need to know that it's a loss in bone density. Is it only in certain bones? No, it's all over the body. So if it's happening at the hip, it's happening in the vertebrae as well. Now, is it happening just in the thoracic vertebrae? No. It's just that these ones are susceptible because that's where that curvature happens, and that's kind of where we just sort of slump with poor posture throughout our life. So this slide is saying that you get severe or exaggerated or abnormal thoracic kyphosis that is secondary, meaning that it's due to an osteoporotic condition. And because the bones are weaker and they can't necessarily support that weight, they start compromising the shape, and that's where you get sort of the little humpback on the back of, small little old ladies is where you usually see this. It can happen with men too, and some of you have seen men that are probably in their 70s and 80s, and they kind of stand like this. All right, so you can kind of see how the bone remodels as a result of osteoporosis, compromising the bony architecture and allowing for a risk of fracture in this location. Patty, I'm going to need the lights down here on the next slide. So if we look at this slide, let me turn those down just a tad so you can see a little bit better. Here you go. Right here, do you see right through here there's this fracture line? These are compression fractures. Here are the ribs coming across, right? Here's the gap in between the two vertebrae. And here you can actually see some exaggeration here of this space and this space are not the same, right? So there's some osteoarthritis happening where you got bone-on-bone erosion. But right through here, this little fracture that takes place, there's two parallel lines that come through. I don't know if you can appreciate that. The red arrows are kind of trying to show you where it is. Well, what's going on here is we've got osteoporotic changes, and over time, as the individual is walking throughout the day for 70, 80 years, it just puts pressure, and that's a compression fracture that takes place right there. So if we move on to the lumbar spine, the lumbar spine, so we've got, backing up, we've got whiplash injury in the neck, cervical spine. We've got compression fractures that take place in the thoracic spine, kind of right at that border between the cervical spine and the thoracic spine where that curve takes place. And if you introduce osteoporosis in that condition, in that patient, you're going to see results of compression fractures. So as we kind of finish our map through the spine, we're down at the lumbar spine. In this situation, we see a lot more force loads happening than we do in the thoracic or the cervical region. Because now, unlike the head being supported by the cervical spine, the lower back or the lumbar region is the head, arms, and all of the trunk. So there's a lot more weight that's happening here. And so we see more routinely vertebral column injuries or issues associated in the lower back, in the lumbar spine. It sustains these repetitive loads all day long. You need to be able to bend down and tie your shoes, right? Take off your shoes. Pick up something that you dropped on the floor. Like I said, you need to be able to twist, right? Many of our injuries on disc problems are actually, believe it or not, loading and unloading the dishwasher. Right? Why? Because you're at the sink, right? You turn and bend, and that's actually the weakest situation for the vertebral disc, is when you turn and then bend. And that's where a lot of those injuries take place. So this is where you probably know somebody that has a back issue, and my guess is it's probably in the lower back. Okay? So what's going on in the spine? The example that we're going to talk about in the lumbar spine is our herniated disc, just because they're so common. Right? And there's always tremendous amount of interest or questions about what's going on with herniated discs. So a herniation is basically just a term that means when a tissue under pressure essentially erupts out of its normal contained location. So you could have hernias that take place in other locations in the body. Like you could have an abdominal hernia where you have tissue within the abdominal cavity that's actually kind of putting pressure inside the body onto other spaces because it's not being contained. And a lot of women post-delivery, maybe many years later, umbilical hernias are actually pretty common, where a hernia develops right around the belly button because the rectus abdominis muscles actually kind of separate out for childbearing, and so that weakens that plane, and then any of that abdominal pressure that normally we might experience may actually herniate out of the umbilicus or the belly button. This is a hernia that's talking about the integrity of the disc. Okay, this is the intravertebral disc, and you can see in this picture we've got a healthy disc here. We have a vertebral body, a healthy disc, vertebral body, so on and so forth. We have these foramina that are formed where the spinal nerves, or here the nerve root of that spinal nerve, is going to exit out of the central nervous system, and now it's part of the peripheral nervous system, which is where we're going after this exam. We'll pick up after the exam with the peripheral nervous system, and we're going to see how these nerves, these spinal nerves, actually integrate. We'll see a little bit of that today as we start making the transition to the PNS. But when you have a herniated disc and it sort of bulges outside of its normal contained shell, it's putting pressure on that nerve root, and it can manifest itself in different ways. Pain, numbness and tingling. It could be coldness. Any of those at various magnitudes could be symptoms of a herniated disc. Okay? So the disc itself, when it's herniated, it's considered slipped. This is another terminology. So I have a slipped disc. So this would be a herniated disc as well. And they could be out of place or they could be completely ruptured. And we'll talk about the differences here in a moment. The most common place for this to take place is actually between L4 and L5 or L5 and S1. That's on the lower back. S1 is sacral 1, right? And so those discs that are lower on the spine, and if you kind of put your hand on the small of your back, kind of where your back kind of comes in right here, like right above your butt crack, that's actually where this location would be. Okay? 80% of the load that is transmitted through the spine at that level comes right through the disc. Well, where's the other 20% go? Well, if you remember, the disc comes down and there's actually these processes, right, bony processes of the inferior and the superior vertebrae, and they actually do kind of interact. And so there's 10% on one side and 10% on the other side. So about 20% goes around the disc and 80% goes right down the middle. Okay? It's a shock absorber. That's how it functions. As we get older, the content of the disc material, which is a collagenous shell, and then it's what? Cartilage inside, right? And you have this outside kind of wrapping, which acts like a little bit like a jelly donut. Okay, so you have the donut, and then you have a hole inside that's full of fluid, right? Jelly, that's kind of the analogy that we have with our intervertebral discs. Now, in the disc surgery, a lot of times what we'll do is we'll either repair it or we'll replace it completely and cut it out. So in this example, can I get the lights one more time, Patty? We've got two different types of imaging modalities. This one's actually showing a CAT scan, and this was an MR scan. And this is actually the disc. And here you can see this bulging outside of where the disc really should be. It should look like this border. And right here you see this white hue that's coming out. And it's putting pressure right here on the nerve root, which is this structure that I'm circling. Over on this side, you can see this is the disc material right here. And here is the bulging disc that's coming out. And it's putting pressure right here on the root of the nerve. So it's pretty obvious to be able to see. We can obviously visualize it. And then what do we do about it? Well, the surgery is actually fairly straightforward most of the time if this is all that's going on. But a lot of patients, there are what we call comorbidities, right? There's other issues happening. So for example, a lot of patients that have lower back problems may be overweight. Not always, but they might be. They might have diabetes associated with their weight gain over the years. They may have other types of problems that we'll look at here in a second with other bony issues of the lower back, of the vertebrae themselves. They might have fractures in those locations. Or they may have vertebrae that are actually out of position that we'll talk about here in just a second. But if you see this bulging disc, right, a herniated disc or a slip disc, it's putting pressure, but this is the jelly donut analogy. The annulus is this ring-like structure, and this ring-like structure is organized in a hatch type of pattern. So it's kind of like this. And as you twist, they line up. And as you come forward, they cross like this. So it acts like the Chinese finger puzzle. Have you ever tried one of those? So the Chinese finger puzzle is this sort of woven mesh, and if you put pressure in one direction, you can kind of line up the fibers and get your fingers out. Okay? That's kind of how your disc orients. So when you're facing this way in anatomical position, that's the strongest that it is. As you twist and turn, the fibers line up of this ring outer covering, and as they line up here, and then you bend over, it's weaker, and the rupture happens between the parallel lines of that annulus, this outer portion. So you can see in this picture, the annulus has actually been torn, and now you have an extruded disc where you're getting sort of the jelly content, or the cartilage is actually out of the sac that it's supposed to be sitting within. Okay, question?
Why does pressure on a nerve cause pain?
Why does pressure on a nerve cause pain? Well, you stimulate that nerve, and if you're putting pressure, just like, you know, if you put pressure on this for a long enough period of time, it's going to become tender. Does that make sense? So have you ever taken a hike and you had a stone in your foot, in your shoe, and then after a couple of miles you're like, that really hurts now, right? And it didn't start out that way. So any pressure on tissue over time is going to cause damage to the tissue. And so that's the same thing that's happening to the nerves. The nerve is being damaged because of that pressure that's being put on it. And the way that it interprets it is as a pain signal. And then you use a pain pathway to tell you what's going on. In other circumstances, it may be you can no longer feel sensation. Or you can feel part of the sensation but not fully. And that's that pins and needles feeling that takes place. So patients will complain of a variety of different things. One is pain, shooting pain, depending upon which nerve it is. Another one might be numbness of the leg that's being affected by if it's on the right or the left side. Another one would be maybe halfway. It feels like my foot's asleep. Does that make sense? Another one is a loss of motor control. If it's a motor nerve that's being pinched, it's coming out of the spine. And so that their gait might be, you know, floppy. Like the foot feels like it flops forward. And it's aggravated. It might be aggravated after the end of the day.
and then when they rest and they decompress the spine, when they lay down, it calms down. And so sometimes anti-inflammatories will work to some level because it reduces the inflammation in that tissue and it relieves some of the pressure put on the nerve. Okay? So there's a lot of physical therapy that can be done in a lot of cases, because you could actually say, all right, well, if we wait enough time and we decompress this bulge, will it actually reabsorb and come back in? And the answer is yes, to some extent. And so that's why physical therapy is super helpful. And in a lot of patients, you can actually put the patient on sort of traction, where you sort of pull gently over time, slowly, and you put pressure pulling apart the vertebrae. So you sit in these traction units, either standing up or laying down, and it pulls the bottom portion of the body one direction and the top portion of the body the other. I mean, slowly and very gently. Usually apply heat, and you might massage the tissue so you don't do any damage. But the idea is doing that 2 or 3 times a week in the clinic. You start separating out the superior from the inferior vertebrae and relieving the pressure on that disc, and then it's allowing it to facilitate reabsorption of the nucleus pulposus, which is the inner component of the disc. Okay? In other cases, there's too much damage and it's completely torn, and so you got to go in and actually remove it. And so in this case, surgically, a lot of times it's a neurosurgeon that'll do this, and they'll come in, or a spinal surgeon, and they cut out the torn part, and a lot of times they'll sew this together. Do they put anything in there? Not routinely, they don't. It sort of has, you know, kind of an area or a region that isn't quite fully inflated, if you will, but it's no longer putting pressure on the nerve root, and so the irritation is gone. Okay? Usually about an hour and a half on average, so some a little less than that, some, if there's complications, maybe 2-3 hour surgeries. This is actually pretty successful for these herniated discs. Now in the lower back, because there's just so much more going on there, I've got a second type of disease that I want to bring up. This one's actually referred to as spondylolisthesis. Spondylolisthesis. So spondylolisthesis is a forward displacement of a vertebrae, so it moves and slides anteriorly. And as it does that, and I'll show you some pictures here, as it does that, it actually is putting pressure on the spinal cord itself. And oftentimes, spondylolisthesis occurs after a break or a fracture of one of these vertebrae. So can I, Patty, I'm sorry, it's like a leg show today, but can we get the legs one more time? So in this picture, what you can see is in this individual, this is birthday of 1946, so you can see this is about, what, 68, 9-year-old male, February 26. So in this case, we're focused down here. You see this? See how the superior vertebrae lines up with the inferior vertebrae? Right? Here, the superior vertebrae sort of lines up with the inferior. But look at this one, superior, and this one's way over here. And this is the anterior aspect, and this is the posterior aspect. Okay? So this vertebrae right here has slid forward. So if you can't tell what we're talking about, just a slightly different image, but this one actually can, I think, better illustrate what's going on. You can even see, you know, that there's some soft tissue here that's kind of pulling forward anteriorly as this is actually sliding. You guys with me? So this is considered spondylolisthesis, and if you look carefully, you can see a fracture right here. You see sort of this sort of parabolic-looking fracture that's following my arrow. So this is spondylolisthesis, and it's categorized in different grades, just for sake of completeness, and we're not going to hold you accountable for the different types of grades, but the severity is grade 1 would be low, and a grade 5 would be pretty severe. And it's based upon how much it slides. So this is probably about a grade 4. So the patient was very, very uncomfortable. A grade 5 would be if this was further beyond halfway on the inferior vertebrae. Okay? So, in summary for this section, we characterized and talked about the 3 different areas or regions of the spinal cord. And we talked about 4 different clinical issues that we see that could make some great test questions. Okay, I'm getting a lot of you in my office, which is awesome. And a lot of the questions are around the lines of, I think I might be studying the wrong stuff. And that's a legit question, right? So the strategy of this class, and I know I sound like a broken record, but I really want you guys to understand how I look at this class. There is a curriculum that's required because this class is actually throughout the entire nation, and we actually have some standards that we have to teach to. And that's why a lot of these textbooks are mostly the same. So if you took it at a community college or a different institution, you'd be exposed to essentially much of the same content. The style is very different, I'm sure, right? There's lots of different ways to accomplish this. But so my strategy or my style is to really expect that you guys are going to come to the lecture having already read the chapter. And that's why I play out what the whole semester looks like, so there aren't any surprises. Then you come to lecture and we talk about content, and I go at a pace where those of you that are looking ahead and looking at the slides or reading ahead like I'm asking, the pace isn't fast. The pace seems very comfortable. If you truly think I lecture too quickly, I would ask you to be honest with yourself. Are you actually doing anything before you show up? Because it's like trying to speak another language if you're just walking in the door. And then a lot of the stuff we just went over really isn't in your textbook. Right? So there's also that. There's stuff that I think is fascinating and interesting. I like the translational stuff. And I get the opportunity in lecture to say, okay, they've been exposed to the whole chapter, so they've seen it. And now what I'm going to do is I'm going to pare down what I think is most interesting and most important. And that's what I'm going to hold you accountable for the exam, is what we lecture on. And then you go back away and you do some more studying, and you have worksheets and quizzes that are also based on the textbook, but you can use the textbook. So then I don't feel bad that we're not lecturing on everything, because we don't have enough time. And that pace would be extremely uncomfortable. And you're exposed to it with worksheets and quizzes, and so we've done our job from a curriculum standpoint. But the other thing that's nice for you guys as students is you know exactly what's expected of you on the exam. And then in lecture, for those that show up, I try to reward you by really trying to focus you on, in that content, the stuff I would really cover is all the clinical translational stuff. Understand give me an example of a disease or a situation that we talked about at each level of the spine. And in the lower back, we talked about too. Okay? Does that make sense? How we do this? Okay, cool. So the last little component for today, and we're going to get a little ways, but we're not going to finish everything because of the way that I like to have things kind of set up. I want to finish out the spinal cord, and then I want to set the stage for our next unit after the exam when we come into the peripheral nervous system. Because remember, we put these compartments around the different segments. Does the body really care that we just left the central nervous system and now we're talking about the periphery? It doesn't really know the difference. It's all one integrated unit, right? And so sometimes we do a disservice. There was a colleague of yours in my office yesterday with a question, and it was a great question. And he asked, he goes, I'm just really wrestling with so how does the signal go from one spot to your foot and then back up and know exactly where to go? Okay? And part of the reason that he's asking this question, which is a really legit question, is because we chop everything up. And so I was able to explain to him the whole route of the reflex arc as it goes out into the periphery. And if you step down with your left foot there's a nerve that comes up, sensory information comes up through the lumbar spine, enters in on the left side, travels up the spinal cord, it crosses over to the right hemisphere, because that controls the left side, right? The right hemisphere in the post-central gyrus, which is the sensory cortex, of that region where it corresponds to programming from the left foot. And then it sends a signal to the precentral gyrus, motor information, and it sends it down, crosses over at the level of the medulla, comes down the spinal cord, exits out the anterior side, and then down to the left foot and says, okay, pick your foot up now. And it just keeps doing that throughout your gait cycle, right? Because now we've just connected the whole system. But right now we're just talking about the central nervous system. And so this individual was like, oh, that's actually super helpful. Sometimes we don't do a great job, myself included, explaining the big picture because we're so focused on, this is chapter 13. That's chapter 14. We won't cover that yet. But sometimes you need to see the whole thing to understand how it works. Okay? So now what we're doing is we're finishing out the central nervous system, and I want to try to go slow because I want to make a nice transition from the central nervous system to the peripheral nervous system, understanding that in that example I just explained to one of your colleagues yesterday in my office, that I just explained to you, is happening all the time right now. As I'm waving my hands, right? As I'm thinking about the next thing to say, as I'm trying to adjust my tie, make sure that my fly's up, right? Make sure that my hands aren't waving too much, wondering if I have a booger on my nose. All of this is happening while we're in motion. Okay? And it's the peripheral nervous system and the central nervous system that interacts constantly. But the way that this is organized now, and imagine that spinal vertebral column on that ring stand in lab. And what we're focused is now, we were just talking about the vertebral bodies, the bony structures. Now we're going to talk about the inside stuff, the actual neural tissue. And this column, this neural tissue, is housed in that central canal, right? And if you think about the anterior aspect, which is ventral, and the posterior aspect, which is dorsal, first off, why do we have different terminologies? Well, I said in the very beginning of the semester, when we were talking about planes and orientation and coronal sectioning versus transverse sectioning, we were talking about medial and lateral. Do you remember that lecture? We talked about anterior and posterior, and I said sometimes we use the word ventral, and sometimes we use the word dorsal. And ventral and dorsal is really referred to with quadrupeds, or lower level vertebrate organisms. And the reason for that is with someone, an individual, an organism that's on 4 legs, the belly is the ventral surface. And that, if you stand up, that's the anterior surface. Well, a lot of neurophysiology originally was being researched using lower level species. And so all of the primary literature in neurophysiology really talks about ventral root horn and dorsal root horn. Dorsal, like a shark, the dorsal fin is on the back. That's how you remember that. So that's where this old terminology comes from, and I like you guys to understand why. I will try my best to remember to put anterior, comma, ventral, posterior, comma, dorsal, okay? But this is the front, this is the back. I won't put front and back. You need to know anterior and posterior, okay? And just like the brain, we said there were 3 axes of organization in the brain. In preparation for Tuesday, what were they again? What's that? The commissure tracts that connect the right side to the left side. That's one axis of organization, right to left.
Front to back.
Front to back, right? And then rostral to caudal, right? From top, head, rostral to caudal, tail, down. And so we know that the back to front organization was sensory towards the back and motor towards the front, right? We also see that same sort of feature in the spinal cord. So in the spinal cord, you see this sort of butterfly-looking pattern? This is gray matter. That's why it looks a little bit more dark. And the white matter is surrounding it. And in the anterior portion, we actually see what we call descending tracts, primarily organized in the anterior portion. Now, how come there's only green on the left side, right, the patient's left, and there's no green on the patient's right? Well, it's just because they're trying to make it clear. This red tract does exist right here as well as right here. And this green descending tract exists right over here in the same location. They're just trying to spatially paint so that you can keep them separate. You with me? So the descending tract is coming down. And as the descending tract comes down from the brain, stays in the central nervous system, that information is sensory or motor? As it comes down? Motor. And it comes down and leaves out the front, right? And so it's colored in green as a descending tract. And as this information is exiting out of here, it's going to exit out what we call the ventral root, or the anterior root, and it has a motor function. Likewise, if we have ascending tracts that send information up, that's sending information up to the brain, that's what kind of information? Is it sensory or motor?
Sensory.
It's sensory. It's conveniently colored in red, so you know that it's going up. But you also know that there are red tracts on the patient's left side of the body as well. It's not like you can't sense anything on the left side of your body. Okay? It's trying to keep the colors from blurring too much. So you kind of superimpose one on the other and see where it would be on the other side. And this information that goes up is going up and coming in from the dorsal aspect, which is the posterior aspect, which is sensory. So the spinal cord, as part of the central nervous system, is also organized in this back to front architecture. Okay? And the information that comes in from the back and then scoots right back out the front at the same level of the spinal cord, what would we call that? What do you guys think that would be considered?
Dorsal root.
This little arc that I reflexively keep doing. A reflex arc. Wow, that's amazing. Nicely done. So this is a reflex arc. And that reflex arc has information that comes in. There's an inner neuron, a connecting neuron, that actually takes it right back out. And that's how you do this. Oh, that's actually not hot. That's fine, right? Remember that analogy that we did? Well, there's an inner neuron that comes and connects it here. There's also an inner neuron that takes it up to the brain and puts it through a couple of different association centers. And that's where you make the decision of, oh, I thought that was going to be hot. I don't even think it's on. Okay? So does this make sense, how this is organized? This is actually pretty important to be able to connect to the next unit and actually for Tuesday's examination. Okay? Now, just for sake of completeness, we have a ventral horn, which is motor, and we have a dorsal horn, which is sensory. The horns are these structures right here. They kind of look like horns. These guys are coming in. These guys are going out. You with me? And these nerves that are leaving are coming out of the horn. These nerves that are going in are coming into the horn. The horn being the gray matter part. Now, the white matter part outside are the projection tracts that go up and down. Now, it doesn't always work this beautifully, but this is a great example to show the simplicity of the organization. Because somebody asked at one point, why wouldn't you myelinate everything? Or maybe it was some question kind of like that in this class, this semester. So I said, why don't you just myelinate the whole nerve? Maybe that was the question. Why don't you just myelinate all of them? Well, this reflex arc, when the information comes in and shoots right back out, does it have a long distance to go? No. In comparison to up to the brain, through a bunch of different brain centers, right? And then you think about whether or not, that fart smelled or if it's fine. And then it comes back down. Is that a long way to go?
Yeah.
Yeah, so does it make more sense that myelinated fibers would take it up and down, and non-myelinated gray matter would be used for just the reflex arc because that's at the local level? Okay. Now that analogy doesn't hold true in every example, but here it actually works out quite well. Now there are some lateral horns, but they're only visible at very specific areas, like between thoracic 2 and L1 of the cord, basically right here. Okay, and what we usually show is we show a prep that looks like this that doesn't show the lateral horns. And so that's what you should expect for the exam, is a picture like this. As we finish out how things are organized, I want to draw some analogies And the analogies that I want to draw are to some things and structures that we've already looked at, and structures that we're going to look at. Yes, sir?
So how would anesthesia work for blocking the nerves?
How does anesthesia work?
Yeah.
Like, what type of anesthesia?
And it could be dental or I don't know.
I mean, like local or general?
General.
Well, so general usually alters consciousness, so you basically go to sleep, right?
You don't feel anything?
Yeah, you really don't feel anything. That's right. And so there's two types of anesthesia. One can be a muscle relaxant or a paralytic. And the other one can be an analgesic as well, where you block pain and you block muscle function, and then you alter consciousness. So like if you ever had like your wisdom teeth pulled, right, and they give you some really dope stuff, don't they? There's that one again. But, you know, the guy's back there kind of making this cocktail in these syringes. You're like, what the? Right? And you got his IV in, and then he just starts, you know, doing his little cocktail dance back there, and you get to like 7 from, you know, counting backwards, like 10, 9, 8, right? And you're just out. So, like, one of them is usually a muscle relaxant, like a ketamine. The other one is a pain reliever, so, you know, when you come to, it's not like throbbing. And then the other one is what actually puts you down, puts you asleep. And so that's why there's multiple things that they're, you know, putting in. So local blocks usually target specific nerves. And so you can give local blocks like in dental applications where you're just focusing on the facial nerve or the trigeminal nerve that's actually within the face and in those applications. You don't have to put the patient all the way down. Okay? So in this case, what I want to show you is I want to kind of dive through this column structure. You're going to see this motif in 3 different tissues. You're going to see it in nerves, you're going to see it in muscle, and we saw it somewhere else already. Where did we see this kind of column organizational structure? In bone. Okay, so the idea that I would compare this to, you see this an awful lot in biology. If the blueprint works, you're probably going to see it show up again. Right? I mean, for example, back to 181 and 182, I mean, most leaves look mostly the same. Right? I mean, there are some kind of funky ones with like more needles, and I mean, I get that. But they're all kind of mostly the same. Like you all, how many of you have an automobile or a bicycle? Raise your hand. Or a skateboard. What is the shape of your wheel? Huh. That hasn't really changed much, right? So you're going to see that this column architecture must obviously be a good blueprint. And so we see it again and again. We saw it in bone. If you go down to the individual fiber, this is the unmyelinated fiber in yellow. Here is a myelinated fiber that has sort of this green little myelin wrapping. Okay? And these are the individual nerves that we've been learning about. These are the individual cells. And that is the membrane of that nerve that we learned about where ions are moving in and out. And if you bundle a number of these individual nerve fibers together, you can see that myelinated and unmyelinated can exist next to each other. Okay? And then you surround them with a membrane known as a, the individual nerve is surrounded with a membrane known as an endoneurium. Endoneurium is inside, right? So it's the one that's, the membrane that's most inside, endo. You put a bunch of these nerves that have an endoneurium around them together in a bundle, and you surround it with a perineurium, perimeter. And that made up of a number of, this is a fascicle now, a number of different fascicles come together, and there's a blood supply. These are vascular elements to get them the appropriate nutrition, just like you see in bone, because want to bet they're not any more than 250 microns away from a blood supply. Right? And then you surround each of these fascicles, who might be considered like an osteon, if we were making the analogy to bone, and you surround it with this epi meaning the surface, like epidermis is the outermost surface of the skin. The epineurium is the outermost covering of the nerves. And this is an individual nerve bundle, right? And that's actually what you're seeing going in and out of the spinal cord. And if we magnify this, you know, in real imagery with a scanning electron microscope, here's a blood vessel pair. Here is an individual fascicle. that's one of these fascicles. It's kind of cool when you think about kind of the Google Earth idea and how, you zoom in and now you're looking at the inside. So in this class, we kind of went the opposite, right? We started the very inside, what's going on. We learned about action potential, and now I'm trying to sort of Google Earth it out so you can understand when we connect out into the periphery, what's going to happen in the next unit. Okay. Last concepts that we're going to touch on are these descending and ascending tracks. And so this was really the question that this student was asking yesterday in my class, or in my office, but we didn't get to it yet. So if you think about these spinal tracks, we've got some information, and this is a descending, this is an ascending example, right? Because it's going up to the somatosensory cortex. So this is exactly this example that I was talking about. So here, if you have receptors, you start down here in the periphery that detect some limb position and pressure, it's going to come in the posterior aspect of the spinal cord, and it's going to come up an ascending track, and this is called a first-order neuron. It's the first neuron on the scene. And it moves up the spinal cord until it gets into the brainstem, which is the medulla, right? Medulla oblongata. And at the medulla oblongata, it actually, what we say, crosses over to the other side. This is a word called decussate. It crosses over to the other side, and then it continues its pathway up. As it continues its pathway up, this is through a second-order neuron. The first-order neuron got it to the medulla. The second-order neuron actually is going to take it to the thalamus. Remember, the thalamus was a relay center. So here's where everything kind of comes together. Via the second-order neuron, it comes up into the thalamus, the relay center, and from here, we're only showing it going to one location, but we know that it could go to multiple locations because that sensation could trigger an emotion or a memory, or it could trigger a thought. But here in the somatosensory cortex, where it's detecting information about sensing, is where it's going to terminate. And this is via a third-order neuron, from the thalamus to the somatosensory cortex. So that's an ascending pathway. Make sense? So some terms that we covered: decussation, where it crosses over at the level of the medulla. Hemidecussation. Hemidecussation is a word we'll talk about here, but we won't see it again until vision. Hemidecussation is where half the information crosses over, the other half stays on the same side. So you get information going to both hemispheres. Hemidecussation. The term contralateral versus ipsilateral. These are terms that are helpful because the contralateral side is the opposite side, the other side. So if it starts in the right leg, it ends up on the contralateral hemisphere. Ipsilateral means same side. So that terminology would be like in the example of hemidecussation with vision, from the right eye, half the information goes and hemidecussates to the left side of the brain, and then the contralateral side, and half the information stays on the ipsilateral side.
Thank you.
Okay? So this is sensory input. Let's look at an example of motor output. Pretty much the same stuff, but now it's actually colored in green, conveniently. Okay? But this is originating up here in the motor cortex. It comes down, and we're seeing signal from both sides. It comes down to the level of the medulla, and this is where you get decussation taking place, in the medulla. And so the signal that came over from the left hemisphere crosses over to the right. Ultimately, in this descending track, it's going to exit out the ventral aspect to skeletal muscles. Okay? Ascending and descending. So this is the lecture, and these are the slides that kind of connect the central nervous system to the peripheral nervous system, which is where we need to start when we get done with the exam next week. And so, in sort of summary with this component, I want to show you it in sort of a broad picture. What we have here is we've got our descending tracks, and they have individual names. Am I going to ask you an example specifically from one of these, like vestibulospinal tract? No. I'm not going to have a slide like this and have you label it. Do I expect that you know that motor is leaving out the ventral aspect, and sensory comes in the posterior aspect. Absolutely. Would I expect you to theoretically be able to trace something through and do what we just did on the last couple of slides? Yes. But for sake of completeness, I want to show you that we've actually labeled exactly where these tracks go and what they do. Okay? Now, the last piece of information, and this is where we're going to stop. This is our last slide, but stay with me, right? We'll probably finish a few minutes early. We have these plexi. A plexi, or a plexus, is a collection or an architecture of nerves. It's a network of intersections. You know, if you've ever been to big cities, not like Flagstaff, but actually we have one intersection that's kind of this way, where you get to the intersection, you can go like four to six different directions. It's not just like one of these. Okay? So like Butler and Huntington, kind of industrial, kind of does that little combo thing here in Flag. That might be the only one. Okay? But that's what a plexus looks like, is an intersection of these nerves. And we've got different plexi in different locations. We have a cervical, brachial, sacral, and coccygeal. In the thoracic, we have nerves here. We just don't call it a plexus. It's not. Because they're not intersecting in this kind of capacity. They actually stay more parallel tracks. They're a little bit more truly organized in the thoracic region. It's not you don't have any nerves there. It's just they're not considered a plexus. But the idea that I want you to take home from this is that the different levels of the spinal cord that we just finished up with and the corresponding plexus that it's going to is how you're going to get a nerve signal to or from the periphery. So for example, let's look at our cervical plexus that's shown right here. Right? We've got C5, C6, C7, and C8, and then here's T1. These are nerves, not vertebrae. You're like, dude, there's no C8. Okay? Yeah, in the nerve there is. Okay? So if you look at coming out of the C5 branch, and you can see how this purple becomes pink, and it can take this pathway. It becomes green, it can go this way, or continue on. So this is truly what the plexus definition means, is you got a nerve coming out, and it's got multiple ways to get there. And that's one of the reasons if you have spinal cord injury at different levels, the doctor's going to say, well, we're going to have to wait and see what the result is. Because there's so many other types of nerves here, I just don't know how much damage there really is. It's not as straightforward as, are they going to be paralyzed or not? And I know as a family member, that's the only thing you want to know. But that's why you're getting this answer of, it depends. We're going to have to see what happens, how they recover, how much damage was truly there. We won't know until the recovery comes in. But you can see at the output, here's the ulnar nerve, right, running down the arm. Here's the median nerve. Here's the musculocutaneous. Here's the radial nerve, another arm muscle, or an arm nerve. Here's the axillary nerve, another arm nerve. So you've got axillary, radial, median, and ulnar. And the ulnar nerve down here can receive information from any of these guys up top. So a fracture, at the level of like C4, C5, means that you might lose all of it. Halfway down, you might lose some and keep the rest. There might be partial paralysis, not full paralysis. Okay? So in the thoracic region, it doesn't look quite intersecting like this. There's not as much redundancy there. A little bit more parallel, straightforward paths. Question?
Yeah, so if you sever just like one of the branches of one of these, not like at the base, this whole neuroplasticity concept is like learning new pathways is more probable to occur with these plexi versus like in the thoracic region.
That's true, but remember, we're in the periphery now. We've just left the central nervous system. These are all, the plexi are all part of the peripheral nervous system. So all of these guys could actually regenerate, right, at some level because they're peripheral nerves. So nerve damage in the periphery is a very different beast.
Yeah.
Okay, this is kind of it's our last slide, but it's critical because it's kind of showing the big picture. It's connecting it to what we're going to talk about after the exam. So let's answer this question. I'll let you go. What's the answer? Analogy, axon to endoneurium. Axon to dendrite, Schwann cell to axon, compact bone to periosteum, perineurum to fascicle, or epineurium to axon. It's an architectural comparison. All right? Like street to sidewalk kind of a thing. What do you think? How many of you like A? How many of you like B? C? D? Or E? C's would have it, and they're right. Okay. All right, folks. We'll pick it up here, starting with reflexes after the next exam.